Professional development, this is really emphasising that we have in place meetings and systems that aim to improve what we're about. And there's different ways of looking at that. I'm not going to go into great detail, but one of them that we've been trying out recently is sitting in on each other's consultations. So I don't know whether any of you experienced that, but as a sort of peer review, encouraging reflective practice, we've put into place where we each would sit in on each other's consultation and give feedback so that the doctor can improve, enhance their skills, and also the doctor who's observing can actually appreciate the skills that the doctor has that they're doing. And all these things have got to be good. They're a bit time-consuming, they slow things down, but there's merit in them. And then finally, again, coming back to leadership and commissioning, hot potato at the moment, and we're very fortunate really in having Graham and Adam, both of whom are pushing at the boundaries there. And although it may seem it creates problems and sacrifices in terms of accessibility, ultimately there's got to be some merit for this practice in those roles. And then the future. Well, I think the future is really interesting from an educational point of view. I mean, I think that there's going to be lots more community-based education, less education in hospitals. That means that the educational environments have to be fit for purpose, and that's a problem in Dartmouth because we really are stuck with the rooms, and I think that has an impact on our ability to deliver quality education. So, you know, obviously a new site would be great for me, I'd love that, but multiple learners, I think one of the real problems that's over the horizon is the number of practice nurses in the UK is going to dry up in the next 10 years because most of them are in their late 40s and 50s. That's going to be a real issue. And part of the problem is that young nurses don't go into practice nursing because they don't experience any time in practices. So there's an initiative going on in Devon just about to start to find placement for student nurses to work in practices, and I think that's something that will be really good, not only just for the practice, but also at a national level. Students, foundation doctors, these are doctors at the old houseman level, and we've had some of those that we probably won't go along that route. The interesting thing here is hospital specialist trainees, and this is speculative, but you could see a situation where the colleges that oversee the quality of training would need to sort of rethink things. But you could see a situation where some hospital specialists actually have attachments in primary care and general practice, and that would enhance their training. They'd be picking up, you know, they'd appreciate the context of general practice and also perhaps some of the specific skills in terms of communication. But it would also be good for the practices because they'd have specialists in effect, although in training, being able to deliver certain specialist care, for example, I don't know, cardiology or endocrinology. So in a nutshell then, I think from a sort of learning, development organisational point of view, I think the practice is in a very strong position, and I think we can build on Matt's legacy, and I think there are a few constraints along, but we certainly have the desire to push things forward so that we can establish ourselves as a sound educational developing organisation which seeks excellence and innovation. And who else better to hand over talking about innovation? Thank you.
Okay. You'll have to adjust your eye lines down a bit now, because, or I can always stand on a chair if it helps. Yeah, thanks. It's sort of often said with organisations that change is inevitable. Change is going to go on around regardless of if we want it or not. And so we've sort of got to change or we're just going to die. So we have got no choice about being involved in change. And I think that's more so now than really ever before. I mean, I might not look like it, but I've been doctor for 16 years, so I haven't seen as many inevitable cycles that sort of go around within the NHS as some of my colleagues have, but I've still, in that relatively short space of time, seen things go around a couple of times. But the changes that are afoot now and the problems with the funding that are afoot now are fundamentally going to change what goes on. And no matter with Andrew Lansley going back to the drawing board and saying, we'll listen and we'll listen, whatever will happen is going to be fairly dramatic. And between now and 2 years' time, essentially there's no more money to go into the NHS. So that's very different to the way things have been over the course of the last, certainly since 1997. It's a very different environment. And the environment in 2 years' time will be fundamentally different to where we are now. And that's really why we're doing this. We have to do this now because we have to move away from an essentially paternalistic process where we decide what happens, where we decide what's best, what you guys want, and actually take on board what you want. Because now, instead of, the NHS is very good at doing lip service to patient participation. It's politically correct, it's a nice thing to do, and it fundamentally just doesn't happen properly. But this is different. And this is a way of actually getting patients' views into designing healthcare systems. And particularly in towns, in small market towns that are finite, that have got edges, that sort of don't have competition in certain ways, there's even more opportunities for you guys to influence how things change. And we've got a 2-year period now of transition where we really, really need to start working together if we're going to do anything properly. Okay. Having said I don't want to do paternalistic, this is sort of, in my head, which is a chaotic place to be at times, this is what I envisage is not mine, but our work plan over the course of the next few years. And it's not an exhaustive list. Within the practice at the moment, Tony does ENT, I do the cardiology stuff. Tony's now offering ENT services to loads more people. And yeah, he might not be here as often, but it's so important. It's so important to the healthcare community in general that everybody gets that level of expertise. It builds up his experience so he's even better where we are now. And that hopefully the same will happen with the cardiology sort of thing as well, that we can offer those services to other people. We can persuade other people that the way that we're doing this, by offering, not consultant, we're not trying to be consultants, but by offering sort of semi-consultant level of expertise as the norm for these conditions, for the patients of Dartmouth, we should be investing in that. We should be helping other people to develop more of those services so that the general level of care that everybody receives just gets better and better and better. And in that, I want to look at developing new areas of expertise. We've got an ageing population, and that's particularly pertinent to Dartmouth. And there may be other things that you think we should be looking at. It takes 2, 3, 4, 5 years to train somebody to Tony's standard or to my standard in those specialities. So we have to think well in advance about what the needs are going to be a few years down the line. And we're much more likely to find out what the right thing to do is by listening to people within a community. We want to develop educational opportunities, as Andrew's alluded to. And we want to continue to address access problem. Now, I've put down access here, and access has got different meanings. Before, when we were talking about access, we were talking about parking and Dr. Anderson's parking tickets. But what I was talking about with access is how you actually get to see doctors, how you get to see nurses, what happens when you ring up, how do we communicate? We need to work on future-proofing things as well. Graham's got an absolute wealth of experience in commissioning, but we've got, it's taken him 20 years to build that up, and we've got to start investing in the practice now to make sure that we continue to take advantage of the type of skills that he's built up over the years. So that's about training us, continuing the educational theme. We've just got to move the surgery. Absolutely got to. And believe me, we've been trying. We have. I've been here 7 years, and it's been there as a theme in the background, looking here, looking there, thinking what we might do for all of that period. And there's been very specific reasons why sometimes it hasn't worked, and sometimes it's looked like it's moving forward and then it's fallen back. But we are absolutely committed to trying to move the surgery to a location that allows services to develop, for us to do new, more innovative things, get more services into Dartmouth so people don't have to travel on the buses that don't exist. And that's just really important. But we're going to need community help in order to do that. And yeah, I talked about increasing services in Dartmouth. But that's just a start. That's what I said. That's my sort of short list. But we could do anything. And we're much more likely to do anything with a bit of lateral thinking, with some participation from people. You know, we were talking today about, well, we do baby immunisations at the surgery, and the surgery sort of, a lot of people don't come in because it's difficult to park and then take a buggy and things like that. So we could go up to the children's centre. Well, why can't we do that? And what are the problems? You know, would people use that? And all of these things, we're much more likely to get ideas if we listen to everybody else, and then we can work through them. And it really is about developing a partnership, and it can only happen through proper consultation and proper communication. We did this when we did tried to revamp the appointment system about 3-4 years ago. We had a meeting at the school. Graham alluded to it earlier. There were 6 or 7 people came. You know, 6 or 7 people, and in these 2 meetings, we've had 120. I mean, that's just fantastic, and it's so good to see so many of my patients here and everybody else. We need to develop that partnership for Dartmouth. And we've been supported over the years by lots of people who've done tireless work, working with Dartmouth Caring, liaising with the practice. But it's the same group of people, and they need help, and we need to expand that. We need so many more people to get involved. And that's the idea of this process, really, that we've got 2 years of challenge. We need to get somewhere completely different, but we can only do it if everybody buys into the same process. Thank you. Okay.
Thank you to the doctors. I hope some, if not most of that, has let you see something that maybe you didn't know before, giving you some new information, perhaps surprised you. It might have made you think things that we're not even expecting, which I'm sure is what's going to happen. But this is kind of the heart of what we're doing now. This is your opportunity to put your hand up, give us a question, give us an opinion, start a discussion. As the doctors have said, and I want to really reiterate this, this is only a start. This is the beginning of what the Dartmouth Medical Practice hopes will be a fruitful and positive and long-running, genuine relationship with the people who use its services. If Dartmouth Medical Practice can't hear you, can't respond, even to say we can't do that, or that's going to be difficult, we don't know how we're going to do that, you guys will never feel engaged. And again, it will be that old-style paternal medical relationship.